Today on Keynote.
Formally or informally, clinical user acceptance testing is going to be a really crucial step in AI adoption because all the statistical and clinical validation in the world doesn't matter if your end users don't trust it.
My name is Bill Russell. I'm a former CIO for a 16 hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Our Keynote show is designed to share conference level value with you every week. Now, let's jump right into the episode. All right, it's Keynote, and today we're joined by Jenny Owens, Senior Artificial Intelligence Program Administrator with Cleveland Clinic. Jenny, welcome to the show.
Bill, I'm so honored to be here. Thank you so much for inviting me on the show. I'm really excited to chat with you.
Well, I'm looking forward to the conversation. Most people now, when I talk about artificial intelligence on the show, they apologize. They're like, man, I'm sorry. There's so much buzz around this. And I'm like, a lot of times the reason there's buzz is there's something there. There's something to be looked at. There's something to be excited about. And so I want to delve into some of that today with you. But before we do that, I'd love to get a brief overview of your role and the evolution of that role at the clinic.
Yeah, absolutely. So a little bit of my background, I had kind of a wandering career path. So I moved from basic sciences into clinical research when I started at the clinic, mumble 2 years ago, procured specimens, did some data entry, and was talking about clinical research and kind of looked at that from start to finish. So I really had a grounding in the laboratory. And that interest in data has kind of driven me through the rest of my career. I was previously in IT and got handed a project to kind of start shaping when our chief digital officer had mentioned, I want to focus on 3 specific areas for our digital strategy. One of those is that I want to use technology to reduce the burden on providers while they're doing documentation. So I got handed that one and I started working on it with a bunch of collaborators. I cannot pretend that it was a solo effort, but I got really interested in not only the technology, but also the implementation and the measurement of the impact. And I kind of worked myself exactly into a new role. So the AI Center at Cleveland Clinic is fairly new, although the people who are in it are not all new. So we've kind of crystallized some of the expertise and the interest from other areas of the organization and put them under a new chief AI officer, Ben Shashahani, who has just joined us in mid-2024. He's phenomenal. His technical expertise is amazing. His perspective, because he comes from outside of healthcare, is really interesting. And watching him interact with a different regulatory environment and a different kind of set of data expectations has been so interesting. There's tons to learn from him. So I'm really excited to be here.
Your responsibility. So what are you focused on primarily for the clinic? What's outcomes for you look like?
Yeah. So in my role, I'm primarily focused on 2 areas. So I'm focused on governance. We have an AI governance group stood up that was stood up under previous folks inside artificial intelligence and data and analytics. So I'm working on iterating with that, trying to clarify the role of governance, trying to streamline some of the processes so that somebody bringing in an AI idea has a clear idea of what do they need to present and what are their next steps. The other thing that I'm really focused on is enablement. And I'm focused kind of on the low end of the funnel. So once you have a model that's been developed, that's been validated, you've had access to all the data, then literally what do you need to do to get it into practice in the healthcare ecosystem? Who needs to be receiving that information? What are they doing with it? What do we need to make sure we've got on the IT side to make sure that it's supported? So those are my 2 main areas of focus.
One of the questions I get asked probably the most, and you're the best person to ask, we're evaluating so many things, right? So there's a lot of tools that are coming to us in the existing applications that we have. So Epic rolled out, 110 new AI type things that it's like configure and go kind of stuff that sometimes could sneak in underneath the governance radar of, somebody just turned that on. How did that get turned on? What's the validity of those models? What are those models from a transparency standpoint and all that? But I'm also getting asked, what's the return? What's the return for the clinician in terms of quality? What's the return from the clinician in terms of experience and efficiency? What's the return for a patient in terms of outcomes and health? I'd love to explore those topics with you a little bit.
Boy, I feel like I could talk with you about this for several hours, honestly. So, whenever we're looking at a new product that's going to enter into our clinical ecosystem or our operational ecosystem, I kind of look at 3 separate things. And that applies whether this is a vendor product that they're trying to sell to us or whether this is a model that we've developed in house. The first one that we want to think about is, does it do what it says on the tin, right? Does the model or the product actually do what it sets out to do? Does it accurately predict a risk of chronic disease? Does it accurately predict sepsis? Does it accurately encapsulate an ambulatory encounter and generate a medical note that is readable and usable for billing? So the first one is, how well does it do what it sets out to do? The second one is, do you see the impacts operationally that you expected to see? So if you're putting in, for example, like a sepsis monitoring algorithm, do you actually see that patients with sepsis are getting their antibiotics earlier? Are they getting the care that they need earlier? Are you seeing mortality rates decline? For the example of like a digital scribe, are you actually seeing notes completed within 24 or 48 hours after an ambulatory encounter? Are you starting to see fewer days to close the encounter as you're looking at data? Are you seeing that doctors are spending less time in their notes outside of their clinical hours? So thinking about, what are the operational impacts that you expect to see? And then can you measure that? Do you know what your baseline is? Will you know what your delta is? And then the third one is, are the people you're hoping to impact feeling that impact? So, and this one is really tricky, right?
Yeah, for those notes, it was pretty interesting because we've had a couple people on the show and they said, yeah, we turned on the ability to respond to inbox and that kind of stuff. I said, well, is it saving the amount of time you thought? And they're like, no, not really. And it varies based on clinicians. Some of them are so highly efficient at what they do that it actually slows them down a bit. Some people just end up deleting, which gives them another step so that they can type the note in. And it's interesting, the experience, it's not uniform across the population, across the groups of people that are using it. And then sometimes it's just hard to measure and get to that number. We want to get to one number, and it's probably a chart of numbers, like it's better for these clinicians, but not for these. How do you have those conversations? Where do those conversations go?
Yeah, so it's really interesting. I think it's helpful to think about a marriage of like quantitative data and then anecdata, right? So you're going to get, especially when you're looking at tools that are aimed at a caregiver experience rather than, improving clinical care or improving patient outcomes. It's really important to be able to kind of quantify, hey, is this having the impact that we thought it was going to? And then to be able to solicit kind of those narrative stories as well. I want to be careful here as I caveat because I spent a lot of time in the AI scribe space and I've talked with a lot of other institutions. So my opinions here are my own and reflect a lot of different expertise, not just my experience at Cleveland Clinic. But what's really interesting is exactly the point that you called out, right? A tool that is tuned for like a primary care practice may not do very well for a cardiologist who's seeing patients, in an outpatient setting. And so it's ideally, if you're going to be piloting something, if you're going to be looking at the impact, you're going to be doing some standard surveys to make sure that you're actually able to measure how clinicians are feeling about the impact of this tool on their documentation experience and be able to marry that with, I mean, we're an Epic shop, so it's signal data, but whatever your dashboard is that's telling you, what are your providers doing after work hours? What is their pajama time metric? What are they doing, at 9 p.m. or at 6 a.m. before they start their day's clinic? To marry that quantitative data about people's actual like in the EHR experience with what they self-report, and then just talking to people. Like we've had people grab their vendors in the hallway when they're there to provide on-site support and say, please tell them that we need this everywhere. This has made my life so much easier. I've heard people at other institutions say that they're delaying retirement because these tools are really helpful. And then I've heard people say, you know what, the way this tool is implemented, it does not cut time out of my documentation experience. It adds time. It's introducing some bloated language that I then have to edit. And that takes me more time than using my smart phrases or, my template that I already have with all of my drop downs. It's really helpful to keep that really close pulse on your tool as you're implementing.
While you were talking, and I was listening, but my scribe was taking notes. I just put it into a Google search, Cleveland Clinic AI solutions.
Mm-hmm.
It's in neuroscience. There is something here about AI assistance with staffing, scheduling, one's tedious tasks. There's comprehensive approach to AI. There's your CEO, the future of AI and quantum computing. How do you manage the noise? Like there's so many, I would imagine there's just so much noise out there. How do you get people focused on, hey, look, I mean, and you sort of mapped it out before. Like, hey, can we baseline this? Are there quantitative measures? Are there subjective measures that we can do interviews and collect that data? How do you stay in front of this, and how do you keep the conversation productive instead of a lot of times where it ends up, which is ethereal?
I mean, there's a lot of things that one can do. And you know as well as I do, Bill, the amount of data that we generate in healthcare is so tempting. It really just seems like we could take that data and use it to do so many things. I think the first cut in making sure everybody is kind of moving in the same direction is to really focus on the problem that you're trying to solve. rather than the solution you think or a potential future that you want, that you can see if only AI could do this, or this technology could do that, is what is the problem that you're trying to solve, and be very clear about that definition. That does kind of drag you down from the strategic into the tactical, but it also makes you grapple with the reality of, oh, if I have an issue with, I don't know, let's say my call centers aren't great. It takes patients a really long time to get through to make an appointment. And then once they make an appointment, maybe they're waiting a long time to get to the appointment and they don't know that they have required testing before that. This is a problem that a lot of health systems are grappling with, but there are there are a lot of other points for improvement in that workflow that are not necessarily artificial intelligence problems to solve, right? These are workflow problems. There are decision trees that could maybe be made more simple. So thinking really clearly about A, what is the problem that you're trying to solve? And then B, what if that solution really needs to be artificial intelligence? And what can be solved with the other tools that we have available to us?
Just flat out automating things and getting good quality data and addressing workflow. What I found is technology is the shortcut. People want to do it because it's easier to say, well, we're going to do this big project around technology. The people side of it, that's the work. It's definitely a heavy lift. I want to go back to scribing a little bit. It is the most prevalent. When I ask people, are you using artificial intelligence? It's the most prevalent thing that people are talking about. The ability to listen to a conversation and to essentially create the transcript of that conversation is, I mean, we now have 12-year-old kids who are doing it. I mean, they
Mhm.
just take the artificial models and pull them out there. The ability to make a good quality soap note, if you will, again, is fairly easy for most of the large language models if you give it the right input and the right approach. When you're looking at these scribe solutions, are you looking at it from a platform perspective? This is a platform for voice across our system. Are you looking at it more for a point solution, like we're going to solve this problem for the clinicians, which is get them focused on the patient more and more accurate in their coding? Or are you looking at a complete workflow where you're saying, no, 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 it doesn't end there. It has to work through the entire system.
So kind of both. And I realize that's an annoying answer, but I'll explain a little bit. So when we're, when
I've
we're
been in healthcare for a long time. It's a very common answer. It's
Mhm.
because it's a complex environment.
Yeah. So when we're looking at Scribe, we're looking for a solution in the first place for a very clearly defined problem, right? Ambulatory encounter documentation, we feel, is taking too long and is taking away from providers' experience. So if it doesn't succeed at that gate, then I kind of don't care, how well it replaces dictation, how well it does other things. If it cannot solve the problem that we asked it to solve, then it's not the solution for us. That's not to say that I wouldn't be thinking about the future, especially with the voice to text technology. I would be thinking about the other places that dictation is used, right? In the pathology lab and radiology, other places where we are dictating, but it's not quite the same setting. So I would also be thinking carefully about my vendor. How does my vendor feel about being asked to push their product outside of its limits? Are they excited about that, or do they not love that?
The integration with your existing systems, how important is that for the AI tools that you're bringing in?
I will say that the literature is quite clear on this. A non-integrated scribe tool in particular does not save providers time. I would be very curious about a workflow that moved some of the documentation workflow out of the EHR and then had providers literally lift and shift it back in. And I'd be very curious to see how that was saving people time and effort.
What specific pain points do you feel AI is uniquely positioned to address within healthcare today?
Wow. So I think about a 2 by 2 grid, right? What do humans do well? What don't humans do well? What does AI do well? And what does AI not do well? AI is great at a couple of things. It's great at taking blobs of text and summarizing them and reshaping them in various ways for various formats. It's also great at ingesting data at scale. So I would put use cases in kind of those two buckets, right? So lots of language based use cases and then lots of large data use cases.
Captain, our beloved service dog, is back for his third year at Vive and Hims. This Week Health is partnering with Alex's Lemonade Stand Foundation to raise $200,000 this year in 2025. It's easy to participate with this. Snap a photo with Captain, share it on social media, tag us, and for every smiling face in the picture, we'll donate $1 to support these families battling pediatric cancer. A huge thanks to our partners, Parlance, Rackspace, and SureTest for making it possible. Join us and let's make a difference together. Visit thisweekhealth.com to learn more. Is AI taking our predictive models to the next level, or are they just enhancing them slightly? Are they incremental gains? Are they
I think we're going to see a real blurring of the distinction between a predictive model and an AI enhanced predictive model, because I feel like this is kind of a continuum on which our data scientists are going to continue to move.
talk to me about integrating AI with existing clinical workflows? I mean, how obviously that's critical. What's the challenge in doing that? We always talk about transparency of these models, and if it's going to be used in the clinical setting, that's so important. In a lot of cases, the models like that's their I don't know, so that's their secret sauce. That's their intellectual property, if you will. I
Mhm.
mean, how do you strike that balance between their intellectual property and our need to understand how these models are making the determinations that they're making?
Yeah, because if you don't understand how the model is ingesting data and working with it and producing its particular output, then it makes it a lot harder to kind of call horse feathers on the output if it feels like it's not aligning with your clinical judgment. I think there's a middle ground of documenting enough of the process in a way that's explainable to a clinician who's maybe not a data scientist. This is the part that I have kind of struggled with, is trying to translate something that is perfectly explicable and understandable to a data scientist, but in a way that your end user is going to be able to not only understand, but also digest on the timescale that they may have to really look at this output, maybe click a thing for more information and kind of understand that. I think it's an area of opportunity, honestly. And I think formally or informally, clinical user acceptance testing is going to be a really crucial step in AI adoption, because all the statistical and clinical validation in the world doesn't matter if your end users don't trust it.
I live in Florida. At some point, you have a health conversation with almost everybody you run into. And, one of the questions I keep getting is how long before this gets down to the patient? Like the patient feels a difference. You talked about call center technology and those kinds of things. If I mention call center to these people, they'll give me their horror stories. They'll say, "Oh gosh, I had to wait on the phone, whatever." Or I got caught in that endless loop of, agent, agent, agent.
Mhm.
I think we're beyond that because that's not really AI. That's just call trees and decision trees and that kind of stuff. And I'm trying to explain to them, it's like, having a conversation with AI feels an awful lot like having conversation with a person. And that line's getting blurred more and more to hear how it's going to impact the patient or where they're going to feel the impact first.
So I think frontline and access is really where the patients will start to feel the impact first. We're starting to focus on how do we open up more appointments to more patients? How do we make sure that patients get in to see their doctors sooner? Maybe they won't feel the direct touch of artificial intelligence there, but as you've got more management of schedules and more effort into the process by which somebody lands on your clinic schedule for that particular day, I think you'll start to feel it. I don't It's interesting because when I'm thinking about how patients are going to feel the effects of AI, a lot of it is going to be kind of diffuse, right? If you're in the outpatient setting, it might look like a reduced time to appointment. If you're on maybe like a diagnostic journey, maybe it's a reduced time to diagnosis, right? If we're able to take advantage of more lab tests, if we're got like AI doing a second read on your imaging, I'm thinking in the very short term future here. If you're inpatient, there's a lot of AI that might be brought to bear on your care. We talked about sepsis risk prediction. We may be looking at some monitoring of hospital acquired infections. We might be looking at ways to manage floor staffing. And are you at a regional hospital or are you at the main hospital? I think a lot of patients are going to feel a lot of it, but they may not know that they feel it. Just like there's a lot of stuff that if we brought it onto the market today would be called artificial intelligence. It's just not called that because it was developed earlier. I'm thinking about like a lot of the innovations in imaging.
The second reads is really interesting to me because I've seen some studies and whatnot where they just took all these reads and they funneled them through. And the AI isn't looking specifically for that cracked femur. It's looking at the entire image and it goes, "Did you look at that?"
Mhm.
And, it's interesting to get that second read. And as a patient, I'm not going to really know that it wasn't the physician that caught that. It was really the AI that said, "Hey, take a look at this." They probably will experience something to that effect. I want to give you the floor and say, what's top of mind? What conversations are you seeing out there or conversations that you like wading into?
Oh my gosh, there's so many. I think the conversations that are really interesting to me are the ones where we get really into the nitty-gritty of what is the impact that we're expecting from any particular tool and how would we know if we felt that? It's not as much as I want everything to be quantifiable, it's not always quantifiable. But to really understand, like if you're looking at an inpatient tool, can you walk the floor? Can you watch people go through their rounds? Can you hang out at the nurse's station and watch as they go from room to room and try to understand what are all the factors that are going into this particular solution, which on my end of the screen is just like a single box on a workflow. That's the part that's really amazing to me, is thinking about the sources of data that are flowing into that, and then the humans who are receiving that output and acting on it. That's fascinating to me. I also really love thinking about the inherent tension in what we do, because on the one hand, a doctor or a nurse who is trying to document care on a patient is trying to minimize the amount that they are interacting with the electronic health record. They want fewer clicks, they want fewer boxes, they want a streamlined workflow. And then on the other hand, you have this enormous appetite for data and discrete data, which requires clicks and drop down menus and this and that. And so the tension between those two is always going to be really interesting for me to explore.
We were trying to build a clinically integrated network in California. If you know anything about California, one of the biggest challenges there is you don't employ those physician practices. They're all part of external entities. And so they said, well, we want to manage this clinically integrated network across this group of patients. And oh, by the way, and this was not an exaggeration, it's close to 100 different EHRs. Go. And you're sitting there going, okay. But one of the things I'm hopeful for around AI is this whole concept of you and I can have a conversation and we can be generating discrete data instead of that big blob of a note or that PDF file and those kinds of things. And that is going to have so many significant downstream effects. I mean, we're going to see research is going to be better, and we're going to be able to identify, risks within the data itself. We're going to be able to accept more data if technology can process it. I can't tell you the number of conversations I had with doctors and they're like, I don't want your Fitbit data. I don't want your Apple Watch data. But more and more you're seeing Apple go, hey, we're going to get FDA certified on this and this and this. And I'm like, well, then that becomes real medical grade data. And I'm not sure why I wouldn't want that in my medical record. And I don't know, maybe as a patient, I'm signing off and saying, look, I'm not holding you liable for this, but I want this to be part of my medical record.
It's interesting because, well, A, we're having this conversation while I'm wearing my Garmin running watch, which is measuring my heart rate and everything as we're talking. So yeah, I think the opportunity to use AI to make sense of patient entered data or other data that the patient is bringing with them. Like I think a lot about the consumer grade genetic kits that were all the rage a few years ago, right? Everybody could get, their Helix or their 20, and that data is still out there and it's still interesting and useful. Like what if you could bring that into the health system and have just like, I don't know, like an AI trained by some board certified molecular pathologists scroll through your Helix stuff and say, hey, maybe we'll bump up that recommendation to see a cardiologist by a couple of years. That'd be cool.
It would be cool. I do want to talk about the future of AI. I remember I have a lot more gray hair than you. My first internship was at M&M Mars in 1988 or 87. I forget which year it was. And I was in the market research and I was one of the first computers in the department. In fact, I was the only computer in the market research department. I was one of the first computers in all of M&M Mars, like the PC on your desk kind of thing. And I remember showing people the spreadsheet and they were looking over my shoulder like, oh, show me how it did that math again. Oh my gosh, that's amazing. And so I sort of feel like we're there again. It's starting again with it. It sort of felt like when the iPhone came out too. I'm like, I think this is going to change the game. And if we were to imagine the phone we're carrying around today and all the things we can do with it versus the phone that came out when it was released, it's very different. I think the same thing's true with AI. I think we go, oh, it'll never do this, it'll never do that. But I'm not sure we know what it's going to do. I mean, the PC did a lot more than a spreadsheet. I mean, where do you see it going? How do you see it evolving? And not only from potentially a technology perspective, but our views at it as a society, self-driving cars. I was just in Arizona. Waymo is everywhere. And I've never been in one, but I'm watching all these cars zoom by me with no driver. And I'm going, how do I feel about that? That's different than I talk to people who are taking Waymo and they're like, look, this is safer than any Uber driver. They're starting to adapt and change with it and say, no, this is good. I'd rather have Waymo driving than my grandmother driving.
I mean, that's a fair point. The thing that's interesting to me about the self-driving cars in particular is I keep up on my reading. I'm aware of the stats. I know they're safer, but it just doesn't feel the same. That tension right there, I think, is what's going to drive a lot of our adoption and our innovation in the future.
But you're the quantitative person, right? So I can pull up stats for accidents today and accidents that lead to death. And like today, 0 will be done by autonomous driving and like 10,000 will be done by humans.
Yeah.
But tomorrow, 1 will be autonomous driving and it will be a fatal accident. Still the 10,000 that were caused by humans, but there's
Yep.
going to be one, and that's one too many.
Where's your headline going to go? And we come up against this a lot in healthcare AI too. How good does it have to be? Does it have to be better than a first year medical student? Does it have to be better than a fourth year medical student? Right? I mean, how good does a self-driving car have to be? Does it have to be better than, your average driver? Does it have to be better than a professional driver? Does it have to be better than, I mean, like, I think there's a lot to be probed at here at our overall acceptance of risk. And I think self-driving is a great example of that. And I think healthcare is another example of that, because it starts to feel like your standard philosophical example, right? The trolley problem. If you don't pull the lever, you're going to hit 5 people. If you do pull the lever, you're going to hit one. But if you pull the lever, then you're responsible, right? If I put this AI model into existence, then I'm responsible for the harm that it causes. Whereas, people getting in accidents on their own, I didn't cause it. It's interesting to think about. I think
Yeah.
3 things are really going to drive the future of healthcare AI. One of them is going to be the technology, right? And obviously, the technology is moving very quickly. And I think where it's going to really come into play is a lot of secondary findings and safety net type stuff. Like, I might go in for my annual physical and be like, oh, did you realize you have a family history of, colon problems? Maybe we should bump up your colonoscopy. You've been complaining about shortness of breath for the past 3 months. Have we thought about, like this or that? Just having like an automatic safety net so that my doctor or my nurse practitioner does not have to think about all of that in their human brain. That's being done for them. The care is still there and the judgment is still there, but the actual like running down of the list and the differentials, maybe some of that is there for them to interact with. The second thing I think is going to be the capacity of the health system then to deal with that. If I go in, like, for example, if I go in for an eye appointment, they image my eye and they're like, ooh, looks like you might have some cardiovascular disease. Can they then get me in to see a cardiologist? Will I be able to be maintained within the same health system? And will health information exchanges be a barrier to making use of all of a particular patient's data?
Interesting.
And then the third one is adoption and how patients feel about it, right? Do I like that? Do I want to go in for my eye appointment and have my whole self taken care of? Or do I want to go in for my eye appointment, have my eye appointment and leave and not worry about it?
There's different risk profiles. I think one of the conversations I have with people is a hospital system is, 150 different businesses all in one. And then we talk about it like it's one thing. Oh, it's healthcare. But there's different risk tolerances across the health system for different things. Like if you're going to, put AI in the cafeteria, blah, 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 that, my risk tolerance is a lot higher than in the OR or any kind of diagnosing or whatever. It's my risk tolerance is it's better. But we also read about these studies. I'm putting you on the hot seat here. So we read about these studies and, you have physicians who are diagnosing, they do the studies based on things where we already know what happened, right? It's a retrospect, but we use doctors and we say, okay, diagnose these things. Then we use AI models and the AI models are, predominantly better, not 100%, but better. But then there's the one that everyone's talking about right now where there was physicians was one level, AI was the highest level, and in between was physicians using AI, which
Mm-hmm.
wasn't as high as AI because the physicians looked at it and said, and used their judgment and said, no, that's not right. And they ended up taking the AI into the wrong direction. And it's that kind of stuff where we go, I absolutely want a human to diagnose me. And I want somebody to diagnose me from Cleveland Clinics a lot better than somebody from down the street. It just is. They're known for being better doctors, or most academic medical centers. If I get cancer, I am not going to any of the hospitals around me. I am getting on a plane and I'm going somewhere. Well, if I can train the models with that level of expertise, doesn't that elevate the doctors down the street from me to actually, come up with a better diagnosis? Because they're going to do the same blood tests, they're going to do the same all those tests, and you filter it through the model, and hopefully the model is trained by a Cleveland Clinic doctor or others, and it comes out with a better diagnosis.
So I want to respond to both of these because I think they're both really interesting. In the first place, anytime you see a paper that comes out that pits physicians against like ChatGPT for diagnosis, look at 2 things. Look at the sample size
Yeah.
and look at what they're actually doing, right? Are they doing the New England Journal of Medicine like case studies? Are they doing ESMLE questions? And then ask yourself, like, okay, well, when was the last time I asked my doctor what their score on like the USMLE was?
That's sort of my point on the second one, which is
Yeah.
we don't know, but I do know that I'm going to get better care at certain facilities. I mean, that's well documented. I'm going to get better
Yeah.
care at certain facilities than others.
Absolutely. And so I do think that artificial intelligence offers us an opportunity to do knowledge sharing and education and training. And again, the sort of clinical support network that if you're at a large academic medical center, you kind of take for granted because you can walk down the hall and tap into the expertise. If you're a physician at a rural hospital, you may not have that. So being able to have an automated or a technological support system in your back pocket may be very helpful. And it may, you're right, overall elevate the quality of care.
I'm just hopeful. Yeah, I want to keep living here because I really like living here.
Yeah.
But I think it was the head of Walmart and Walmart has all this, they're the largest employer in the country, or at least they had been for many years. And they essentially were self-insured. So they had just tons of statistics. And they were able to say, hey, look, this number of our cancer patients received either the wrong diagnosis or the wrong treatment plan based on, escalated, because what Walmart would do is they sign deals with you and others, whatever. And if somebody presents with a certain diagnosis, they actually fly them somewhere else for a second opinion. And if they're partnered with cancer centers, they're partnered with others. And so they were able to say, look, here's just the sheer numbers, the number of people receiving. And I'm hopeful that we use AI where it can be used and it can elevate the outcomes across a wider spectrum. I don't expect it to replace the person who has studied for decades and decades and has seen things that AI will never see. But my hope is that it can be applied to those places that are underserved or we just don't have the expertise there.
Yeah. I think my hope is that as we start to get some AI support for diagnosis and for treatment plans, right? If we're thinking again about the short to medium term future, I would hope that we could also get it to take into account some of the patient autonomy that might result in a different path than might be strictly medically indicated, right? You spoke about cancer treatment, right? There's a lot of decision points that go into your cancer treatment, and what is absolutely clinically recommended may not be the best fit for that patient. I think it'd be really interesting to start to see some patient voices in some of this as well. And that's the other thing that I'm really hopeful about is that the artificial intelligence gives a great opportunity for patients to be participatory in their care in ways that maybe they currently don't have available to them. And that's really exciting too.
People actually taking ownership of their own health. What a novel, what a novel concept that would be. But yes, that would definitely change the game. Jenny, I want to thank you for your time. I want to thank you for the work you're doing. And I look forward to keeping in touch and hearing how things progress.
I'm so honored to have been able to speak with you today. Thank you so much, Bill.
Thanks for listening to this week's Keynote. If you found value, share it with a peer. It's a great chance to discuss and in some cases start a mentoring relationship. One way you can support the show is to subscribe and leave us a rating. Love it if you could do that. Thanks for listening. That's all for now.